Hello, and welcome to the Sara Clinical Education Oncology Podcast. I'm your host, Amber Williams. Today's episode features Dr. Shanu Modi from the Memorial Sloan Kettering Cancer Center and Dr. Sara Hurvitz from the Fred Hutchinson Cancer Center discussing the latest developments in HER2-positive breast cancer. They examined the paradigm-changing results of the DESTINY-Breast11 and DESTINY-Breast05 trials and how these data impact their clinical practice in the neoadjuvant, adjuvant, and possibly metastatic settings. This episode is part of a larger educational program titled Optimizing Sequencing of HER2-Targeted Therapies Across the Breast Cancer Continuum, Practical Strategies for Community Oncology Teams. For more information on Dr. Modi and Dr. Hurvitz, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
Hi, my name is Shanu Modi. I'm a breast medical oncologist at New York City and Memorial Sloan Kettering, and I'm joined today by Dr. Sara Hurvitz, who is also a breast medical oncologist and director of the clinical research division at the Fred Hutchinson Cancer Center in Seattle, amongst the many other hats she wears. So welcome, Sara.
Oh, great to be here. Thank you.
So we're here together to discuss updates in early stage HER2-positive breast cancer. And I think to me, that means we need to discuss the two big trials from last year, which are DESTINY-Breast11 and DESTINY-Breast05. So, you and I have been involved with HER2-positive clinical research for, I think, a good part of both of our careers. And I would say it's been a fairly predictable field, right? It's very algorithm driven. We have a lot of consensus. It's a pretty easy conversation in oncology. I feel like that predictability has kind of been upended this past year with these two trials, and it's really opened things up. And now we have new options, but also potentially less uniformity, I think, in our approaches. So I think it makes it more interesting and obviously allows us to tailor therapy. So it's a great conversation, I think, that we're going to have. Maybe before we launch into DB11 data, why don't I ask you to walk us through, how have you been sequencing therapy in the neoadjuvant adjuvant setting for early stage disease before these trials? What is the standard?
Yeah, it certainly has become increasingly tricky and long consultations and discussions now, whereas before we had sort of a standard way to manage early stage breast cancer that was HER2 positive and frontline metastatic. And now, boy, we'll talk about options and the embarrassment of riches. So prior to the readout of Destiny Breast 11 and 5, my standard of care for somebody with stage 2 to 3 non-metastatic breast cancer that was HER2 positive was for a healthy patient to offer the TCHP regimen. In the past, ACTHP had been also, or ACTH was also a standard. It was the original standard. But I think we've seen a lot of evidence mounting showing that omission of the anthracycline is safer, does not appear to have worse outcomes to omit the anthracycline and use the TCHP regimen. And in some cases, numerically, the pathologic complete response rate or longer term outcome may even be better. And so I think really, maybe 5 years ago, NCCN guidelines shifted to moving ACTH based therapy to an other regimen, whereas the TCHP has sort of been the regimen. For a patient with a smaller T1 HER2 positive breast cancer that was node negative, I think many of us grappled with whether we would start with a APT type regimen or THP in the neoadjuvant setting, and then choosing what to do, especially if they were T1C, based on the pathologic response. But in the very small T1A, T1B setting, I think waiting for the adjuvant setting was perfectly appropriate. Many of us adopted single agent paclitaxel trastuzumab based on the APT trial.
Yeah. I think we're pretty aligned in that. And this has been, I think, a real standard way of treating HER2 positive early stage breast cancer. So DB11, I think, was a really important study. The first trial to bring TDXD or trastuzumab deruxtecan to early stage HER2 positive breast cancer is also really the first time we're seeing a new regimen in a phase 3 trial show superiority over a standard of care treatment for early stage HER2 positive disease, not just equivalence, as you were saying. So, Just to briefly remind the audience, I mean, Destiny 11 was a randomized global phase 3 study. It was for patients who had high risk HER2-positive breast cancer, and they were randomized to one of three neoadjuvant therapies. So the standard of care arm, which was dose dense ACTHP, a monotherapy TDXD arm of 8 cycles, or a sequenced TDXD arm. So 4 cycles of TDXD followed by 4 cycles of THP. And the primary endpoint, of course, was to look at PATH-CR. And I think, as we all heard, the monotherapy arm, surprisingly, was closed early due to a low PATH-CR rate. But so in the end, I mean, Destiny 11 is really a study comparing two arms, right? The standard of care and the sequence TDXD THP. And so great data, of course. We saw a very impressive, statistically significant improvement in PATH-CR rate in favor of the TDXD arm. 56% PATH-CR with ACTHP, moving up to 67% with the TDXD sequence arm. So a gain of 11% in PATH-CR. And this was seen, we saw this advantage in the hormone positive patients. We saw it in the hormone receptor negative patients. And at this early point, even a trend for event-free survival. And I think what was the most important corollary to all of this was the safety. And I think what we saw was the safety profile also favored the TDXD arm, which was a little bit surprising, but reassuring to see. And so in many ways, I saw this kind of as a win-win trial for patients. So my question to you is, I mean, what were your impressions of the data and key takeaways?
Yeah, I agree. It's a very unique study and the first of its kind to demonstrate an ADC can replace a component of chemotherapy in the neoadjuvant setting. The Christine trial that tried that, obviously, with TDM1 pertuzumab did not meet that level of evidence. The PATH-CR rate was significantly inferior to a TCHP regimen. So this is historic in many ways. I thought the data were very interesting. I think many of us in the US criticized it for not using the TCHP arm as the comparison arm. But that said, as I said earlier, TCHP and ACTHP seem to have similar outcomes. I would call out that this was a high risk patient population, and the majority of patients, almost three quarters, had estrogen receptor co expression of their tumors. It was also very uncommon to have node negative. Under 10% had node negative disease. So I wouldn't necessarily apply these data to patients with a N0 breast cancer, but the
Yeah.
improvement in PASS-CR was certainly notable, statistically significant for both ER positive and ER negative. EFS was not different. It wasn't powered for EFS. I think people talk about the trend being in that direction. There's really only 7 events that span the two arms, that differ between the two arms. So I'm not ready to say that those are long-term outcome in support of the use of it in the neoadjuvant setting. If it were the only thing presented at ESMO, it would have been a standalone, I think, change in the practice of care, but it was presented the same day as the DBO5 data were presented. And I think that that impacted, almost got overshadowed, in my opinion, by DBO5.
So that's interesting. I mean, I think you raised so many good points there. So first of all, the DB11 really was a very high risk population, right? I mean, they were careful in choosing those patients, given the risk benefit, right? So appropriately done, I would say. Were you surprised by the FDA sort of giving that broad approval, for all stage 2 and all stage 3 patients? And I mean, it sounds like you're not really gonna use it in that fashion, right? I mean, really limit it to your higher risk population?
Yeah, I mean, I think it's interesting that FDA seems to be giving broader approvals, giving, I think, clinicians the freedom to practice the art of medicine within the confines, but not perfectly matching the trial population and the eligibility criteria. And I don't think that's the incorrect thing. I think it's really incumbent upon us to interpret the data and look at the patients sitting before us, as well as their comorbidities and how likely they are to tolerate a given therapy while making an appropriate decision.
Yeah, totally agree. I think that was a welcome decision in many ways. It does allow us to, I think, individualize treatment, as you said. What did you think about the ILD rates? I mean, those were really reassuring, I thought, right? 4 cycles, we saw about 4% in both arms of the trial. Very reassuring. I mean, how are you planning to monitor patients if you're going to use this approach?
Very reassuring indeed, keeping in mind patients only received 4 doses of TDXD, and the arm that actually was superior was a bit surprising to see ILD and ACTHP arm when we don't really see that clinically. But because they're being monitored every 6 weeks, I think, you're going to pick up that asymptomatic ILD, and perhaps our focus and attention on ILD is biasing or making us call it more than we would have in the past 10 years ago when a lot of these other trials were being done. So, very reassuring. I still think patients should be monitored intensively. It's the curative setting. To lose a patient of ILD because there are grade 5 events that occur would be a tragedy in the curative setting like this. So, I think it'll be tough to get every 6 week scans just scheduled, ordered and scheduled and approved by insurance. But I would try to do it every 8 weeks at least.
Yeah, I think so. I think they did do those scans even in the control arm, the Q6 weeks. So we saw ILD rates that we didn't know about even with ACTHP. So it was very illuminating. Let's jump for a moment to DB05, another important global phase 3 trial. As you said, both were presented at the same time, and you couldn't give either one their due, right? But this was once again a very carefully curated population of high risk HER2-positive patients. So, with residual disease in spite of standard neoadjuvant treatment, and then randomized to either TDM1 for 14 cycles or TDXD, so modeled right after the Kettering trial. And the primary endpoint was met. We saw a very impressive, statistically significant improvement in invasive disease-free survival in favor of TDXD with a hazard ratio of 0.47. So more than a 50% decrease in the risk of recurrence on the TDXD arm. And when we look at the 3-year IDFS rates, 84% with TDM1 and 92% with TDXD. I mean, that's a delta of almost 9%. And it's even, I think, more impressive when you consider that these were the highest risk, residual disease patients. So for me, I think this was one of the most exciting results from last year and that ESMO meeting. The FDA, again, gave Destiny 5 that really broad label. We have the option to use this, I think, based on discretion for patients who've done at least some neoadjuvant taxane trastuzumab-based therapy and have residual invasive disease. So not the strict DB05 population. Now come the really hard questions. So how are you going to choose between, you have a high-risk patient sitting in front of you in the clinic tomorrow, and you've got both of these trials, a lot of options, right? I mean, a lot of flexibility now. I mean, how are you going to select the choice of therapy for this person? What's
Well,
more important, I guess? Is it PAT-CR? Is that the critical endpoint for you? Or are you more in line with the idea we can reserve escalation for a selected population, and that's your preferred strategy?
I try to echo the eligibility criteria of a trial as much as possible when I'm applying data. And I do appreciate the freedom that the FDA has given us to select therapy, use the factors we have associated with the patient before us to make the right decision for them. A 29-year-old with high risk disease is different from somebody who's got a lot of comorbidities and competing issues, for example. So there's a lot of clinical features we have to digest as we're making our recommendations. That said, I think I for a very high risk patient, as you said, patients to get on this study had to have inoperable disease at diagnosis or lymph node metastases at the time of surgery. So it wasn't just a little bit in the breast, and unless they were inoperable from the get go. And so for my highest risk patients, I would rather give them the treatment that you can give longer, 14 cycles, and that is associated with a clear invasive-free survival benefit. And I trust that ultimately we'll see survival benefit because I think the data are as compelling as Catherine were when they were presented. And I would prefer to use that after proving that the patient needs it, because there are some patients who appear very high risk at the get-go when you have the diagnosis, but you give them TCHP, for example, and the disease melts and it's all gone at the time of surgery. And really, they probably don't need TDXT. So my bias is to use it that way. That said, if there is a patient who I start on THP or maybe even TCHP, and I go 3 or 4 cycles, and I always do image midway, and it's really not responding, and there's clearly going to be residual disease. The NCCN guidelines allow us to reverse the orders. Maybe then that's when I switch to TDXD and give that to try and get that past CR. Past CR is important, but long term, it's the IDFS that's compelling. And the final thing I'd say is, we see in the metastatic setting, as you well know, CNS benefit with TDXT over and over again. And so for the very high risk patients, having the opportunity to use it in the adjuvant setting for 14 cycles, I think makes me feel like we're doing more to protect the brain.
Yeah, I think this keeps coming up. It's certainly, and there was some, I think, indication, although it's pretty early right now in these trials to definitively say anything, but a hint that we may be seeing some benefits from TDXD in the CNS space as well in early stage disease. Are there any scenarios where you might use TDXD in the neoadjuvant setting and then follow it up with more TDXD in the adjuvant setting, sequencing almost DB11 and DB05, if you will?
Yeah, that's a great question. I've actually been discussing this with colleagues at conferences and at my institution as well, because the FDA was clear that it's an either or, not a both. But NCCN guidelines, I think, are more permissive. Think that I might do that, because what do you do in a patient who's had what you think is a clinical response to neoadjuvant TDXD for 4 cycles, but there's residual disease in the nodes, especially knowing that TDM1 requires high homogeneous levels of HER2 expression for activity. And TDXD may be selecting out and killing those HER2 overexpressing cancer cells. So in that situation, it might be better to continue the TDXT. So I think I would. What about you?
Yeah, it's a really difficult question, right? Because it comes down to the point is, what does that residual disease represent, right? Is it resistant disease or is it just insufficient therapy? And we don't really know, I think, how many cycles of TDXD we really should be giving. Is it 4? Is it 14? I think. And I will say this one thing we have never done before is give more cycles of the same drug when we have residual disease. I mean, we don't give more THP, right? When we have residual disease, we traditionally have moved to an alternate therapy. And I think it was kind of interesting. We looked at the monotherapy TDXD arm of 8 cycles, right? We didn't really see an impressive path CR there. It was higher to switch out to use 4 and 4 of something else. So but it's a question, like you said, it keeps rearing its head because nobody really knows what to do after TDXD, right? What's really going to work? And we're concerned about the potential lowering of the HER2 levels and how well does TDM1 perform there. And then, of course, you're also going to, how many cycles do you give? Do you commit to 14 and then ILD becomes a real risk again, I think. So a lot of unanswered questions. And the reality is most of these patients will be hormone positive patients as well. And so we have great endocrine therapy to offer and is more ADC therapy what they really need. So I think there's so many factors to consider in that decision. So I don't think we're going to have one single easy answer for all of the scenarios really. So it's a data-free zone, right? I think at the end of the day, I view it as we have a lot of standard of care options, even potentially giving more AC chemotherapy for high residual burden. This is probably a great place for a clinical trial. I think this is something we're going to have to at some point address looking at the residual disease and the biology and figuring out what is really the right thing to do for these patients.
Yeah, and to your point about endocrine therapy, the data that came out of San Antonio indicating that we really do need to treat aggressively
Mm,
with endocrine therapy, even in HER2 positive disease, sort of was a little bit paradigm changing, right? Because we were thinking it's all about the driver amplification and it is important. So I do think that should be taken into consideration when we're dealing
yeah.
with residual disease.
Absolutely. I'm going to switch us for a moment now. I think just touch upon metastatic setting and the first line metastatic setting, because the other really big trial that came out just recently was the Destiny Breast 09. It feels like a long time ago now, which was a first line study. And again, it was a big practice changing trial in the field, where we have the option now to use TDXD plus pertuzumab as first line therapy, really displaced Cleopatra after more than a decade, first combination to do that too. And so in is has that become your new first line? Is that what you're using standardly?
Well, I know, just like we started in the beginning, it's become super complicated. It was so simple for like 10
Right.
years, so
Yes.
simple. And I wouldn't say I'm doing that for everyone, but it certainly enters the discussion.
Yeah.
We don't yet
Really?
have the single agent TDXT data from
Mm.
that study, which may change things. We don't have survival yet. There wasn't crossover built in, so we don't know that patients are how much they're losing by waiting till the second line or if they're losing anything. So there's unanswered questions. But for somebody with very symptomatic visceral metastases, liver dysfunction, previous exposure to taxane and trastuzumab, maybe ER negative disease where your maintenance options may be a little less. I definitely discuss it with patients. The PFS data are super compelling, but it's
Yeah.
not just a simple knee jerk
Right.
reaction.
And I think one of those scenarios where we're potentially seeing a divergence in practice is that hormone positive, HER2 positive patient population again, right? With the patina data. And I mean, always do it cautiously, but the cross trial comparisons, I mean, really impressive numbers, right? We're in the same ballpark potentially, and adding CDK4/6 inhibitor was very, very impressive. So and following right along that was the HER2 Climo 5, as you said, and compelling for a lot of reasons too, the brain met potential and specifically for those hormone receptor negative patients. So a lot of things happening in this space. I think one of the things, coming back to the early stage setting, as are going to now use TDXE for our early stage patients, how will this affect that first line metastatic setting now? I mean, thankfully, we're probably not seeing them today, but it won't be a lot of patients, I hope, but there will be some patients who are going to relapse from early stage TDXC. And so what is your first line approach looking in that scenario?
I think it's going to depend on whether or not there are CNS metastases and how long it was, the disease free interval from receipt of last TDXD, what agents are available at that time. There's a lot in discovery now for patients exposed to prior TDXD. So we may have something like zanidatamab, zongertinib, evorpacept. We just don't know how it's going to look by the time we start seeing these patients.
Right.
What about you?
Yeah, I think you hit on the key point for me as well is what's that disease-free interval look like from the prior TDXD. I think that's sort of been a pattern of practice, whether it's right or wrong. But that, 12-month magic number, we've used that a lot. And the longer the interval, the more likely I think I am to go back to something like TDXD as a first line option. And in those rapid relapsers, I mean, yeah, that's going to be a very challenging patient population, I think, to treat. We may even think about going back to something like THP potentially, and I think biology is going to have to really guide us as to what works for those patients. So, still so much more work left to do, right? Two steps forward, and still many, many more to go. So listen, I think we covered so much territory, and we certainly made it through, I think, some of the key paradigm shifting HER2 positive trials of last year. So thank you, Sarah, for sharing your insights. It's always a pleasure to talk to you about science, medicine, and HER2 positive breast cancer.
Thanks so much, Mel.
I also want to mention that I will be working on a CME certified video module and an interactive example patient case that'll be posted on the DeSera Clinical Education website. elaborating on the data some more and best practices for neoadjuvant treatment. So thank you, everyone, for listening with us. And until next time.
Thank you, Dr. Modi and Dr. Hurvitz. And many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Optimizing Sequencing of HER2-Targeted Therapies Across the Breast Cancer Continuum, Practical Strategies for Community Oncology Teams, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.